Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. In continuity with the previous lecture, today we are going to discuss on posture, equilibrium, and gait. All my video lectures are mainly for educative purpose. So posture, equilibrium, or we call balance, and gait. Posture is a stance when the person is static and what type of posture he has acquired. It can give you an idea regarding good number of neurological disorders. Balance disorders is another condition which is very commonly seen with disorders of cerebellum, vestibular apparatus, sensory system, etc., which are taking part in maintenance of equilibrium. And disorders of nervous system will also produce disturbances in gait. So we'll be talking about posture, equilibrium, and gait. So this is a posture, static. When he walks, we call that as a gait. And maintenance of posture is by maintenance of equilibrium. So posture or stand means unconscious adjustment of tone in different muscle concern, accompanying every movement with the purpose of making a movement smooth and accurate and maintaining the line of gravity constantly, and that is called equilibrium. So the position of the body at a given point in the time we call that as a posture, and posture is characterized by specific landmarks being aligned with the force of gravity, keeping the body as close to physiological equilibrium as possible. So for maintenance of posture also you require equilibrium. This is one type of a posture. You can see here while playing, this is a posture. This is another posture. This is while doing an activity. Posture is a state of equilibrium in the space or a position adopted by an individual in the environment. So that is called posture. Posture is also described as an active muscular resistance against displacement of the body by the gravity and accelerating forces. So posture is regulated by number of postural reflexes. There are static reflexes involves sustained muscle contraction, and dynamic reflexes involves transient muscle contraction. There are ascending tracts, there are descending tracts, and there is a peripheral nervous system. So postural control is controlling the body position in the space for a dual purpose of stability and orientation. And it will require musculoskeletal component, adaptive mechanism, anticipatory mechanism, internal representation, sensory input, individual sensory system, and neuromuscular synergy. All this is required for postural control. So for maintenance of posture, you will require sensory input. You will require that sensory input is by means of ascending tracts and vestibular tracts from vestibular nucleus and cerebellum and its connections, extrapyramidal system which takes part in maintenance of tone, and pyramidal tract Those are descending tracts which takes part in voluntary movement. So all this system takes part in maintenance of posture, and particularly cerebellum will take part in maintenance of equilibrium and balance. So pyramidal tract can act on the muscle. Muscle must have an optimum tone. Tone is regulated by extrapyramidal system and cerebellum, and it is supported by local reflex arc, which tries to maintain optimum tone in the muscle. Tone will be increased or decreased by excitatory or inhibitory tracts of extrapyramidal system and by cerebellum. So tone will be maintained by extrapyramidal system and cerebellum. And also the pyramidal tract will be acting on a muscle to maintain the smooth movement, and muscle must have an optimum tone, and that tone is maintained by two systems, that is extrapyramidal system and cerebellum. So for maintenance of posture, you require all this system to be intact. So for action of pyramidal tract, muscle must have an optimum tone which is maintained by extrapyramidal system, cerebellum, sensory input as well as vestibular apparatus, but mainly by extrapyramidal and cerebellum. Bone should be normal. There should not be any deformity. Because of deformity, the person will find difficulty in maintenance of posture as well as equilibrium. Joints should be normal, because even if a person has got arthritis or arthralgia or ankylosis, then again the posture and equilibrium will be disturbed. There should not be any spine deformity like kyphosis, gibbous, scoliosis, because that will also disturb the posture and maintenance of equilibrium. Muscle should not have any myalgia, fibrosis or myopathy, because for maintenance of posture and equilibrium you require normal group of muscles. So there are postural reflexes which are concerned with spinal cord. We call it the spinal cord reflexes, which are stretch reflex, positive supporting reaction, or also called as a magnet reaction, negative supporting reaction, and mass reflex. These are concerned with spinal cord. While with the brainstem, vestibular reflexes, or it is called tonic labyrinthine reflex, tonic neck reflexes, neck writing reflex, labyrinthine writing reflex, body on head writing reflex, body on body writing reflex, etc. So there will be spinal cord reflexes, brainstem reflexes, and cortical reflexes. And cortical reflexes are optical writing reflex, placing reaction, hoping reaction, etc. We are not going in detail regarding any one of this. So there are a lot of reflexes which are all mentioned here, whatever we have mentioned before. Stretch reflex, positive supportive reflex, negative supportive reaction, tonic reflex, tonic neck reflex, labyrinthine reflex, neck writing reflex, body on head, body on body, optical writing reflex, placing reaction, and hoping reaction. What are the stimulus, what is the response, which are the receptor, and which part of the nervous system is taking part in those reflexes is mentioned here. You can go through here at leisure time. So normal posture, when a person acquires a supine, we call supine posture. If he's in the sitting, we call sitting posture, or we call erect posture, or we use the word standing or vertical. Whenever he's acquiring this particular posture, you look for any abnormality and that in that posture, say in supine posture, if there is an opisthotonus, meaning the spine is curved back because of spasm of paraspinal muscles. This is called opisthotonus, which will be very commonly seen in tetanus and meningitis. And this particular spasm is being stimulated by light, sometime by sound, we call photophobia, and that will produce spasm. So person will turn against the light and will curve back. That is typical posture which will be acquired in tetanus and meningitis. In sitting posture, person might have sometime no movement. That's why it is called akinetic, and person is absolutely not communicating with any other person. So it is called akinetic mute, very commonly seen in schizophrenia. And in a person with Parkinsonism, he acquires a absolutely expressionless face, or we call mask-like face, with stare look. So that is typical in Parkinsonism. In a standing, person will acquire in a Parkinsonism little bend forward, we call stoop forward. Eye will be fixed to the ground, and that is typical posture which is being acquired. It is called stooping posture, stoop forward posture, typical in Parkinsonism. And good number of time in cerebellum, cerebellar disorders, vestibular disorders, and sensory disorders, person will not be able to maintain the erect posture. He will have wobbling, and that is called ataxia. And in that, even your Romberg test will be positive. So that is very typical. While a person who has got a damage to the cerebral cortex, he acquires a flexor posture, we call decorticate posture. In a damage to the extensive damage to the brain, we call decerebrate posture, where person has got an extensor position. And very bad damage to the pons and medulla, the person will have a completely flaccid posture. So these are the different posture which sometimes gives you an idea or clue regarding the neurological disorders. Deformities of the spines, joints, bones, muscle, etc. can also give little idea. Like scoliosis is very common in muscular dystrophy, syringomyelia, and also in case of Friedreich's ataxia. Lumbar lordosis is very frequently seen in a Duchenne myopathy, or we call muscular dystrophy. Ataxia we already mentioned, classically seen in sensory, cerebellar, vestibular, and sometimes the person we call as a hysterical person can also present with any one of these abnormal posture. Rigid spine, particularly opisthotonus, will be seen very classical in case of meningitis and tetanus. And you will have also, we call neck rigidity, very commonly seen in meningitis. Spine will be almost straight in case of ankylosing spondylitis. And in case of a pot spine, you will have a deformity like gibbous, kyphosis, very, very common in pot spine. This is right lateral position in supine, because he is lying down on the right side, so it is called right lateral position. This is prone position. This is decorticate. This is decerebrate, or we call extensor. This is flexor. You can see flexion of the upper limb, that is flexion at elbow, flexion at wrist, flexion of the finger and thumbs, and there is a extension at knee but internal rotation at hip. While here, if you see, there is an extension at elbow and you have got internal rotation with flexion of fingers, and there will be extension of knee, while in case of a, you will have a flaccid posture when there is a very bad damage to pons or medulla. You can have an abnormal posture because of a abnormality in certain other structures. like psychological factors, poor postural habits, some respiratory conditions, general weakness, loss of ability to perceive the position of your own body, obesity, pregnancy, high heel shoes, shortening of muscles, decreasing flexibility, etc. This is typical Parkinsonism posture. The person will be taking the support of the side in case of a cerebellar ataxia because he has got truncal ataxia and person is not able to maintain the posture. He will have tendency to fall on the either side. Tubercular meningitis, very frequently he will have photophobia and he might have even opisthotonus. Neck rigidity may be positive. So neck rigidity will be very commonly seen in case of tubercular meningitis, tetanus, those conditions. You can have an abnormal posture in a truncal dystonia. Ataxic posture will usually take the support of some wall or even support with the stick. Muscular dystrophy will have excessive lumbar lordosis. Because of bony deformity, you can have a coxa vara, coxa valgus, telepoequinovirus can also produce abnormal posture because of bony deformity. There is one test called as a wall test which is very frequently utilized to identify the abnormality in spine, particularly in ankylosing spondylitis. That is called wall test. So while examining for the posture in an erect posture, you look from lateral side anteriorly and also posteriorly. When you look posteriorly, you will be able to identify the abnormality of spine like scoliosis, kyphosis, gibbus. For gibbus and kyphosis, lateral view is more important. So you have to examine in a vertical posture or erect posture, lateral view, anterior as well as posterior to identify the deformity of spine as well as abnormality in any particular posture like kyphosis. This is excessive lumbar lordosis. You can see excessive lumbar lordosis. This is erect posture. Not much amount of lordosis. Here you can see that lordosis is also there and there is also little amount of kyphosis. So you will have to look laterally as well as anteriorly also. Here there is a flat posture. This is lordosis. And this is kyphosis plus lordosis. So kypholordotic posture. Here you can see scoliosis. Here there is a scapular winging of scapula. Equilibrium is maintenance of gravity constantly by taking the help of arm or objects or spreading the leg out without the help of eye. And for maintenance of equilibrium, you will require cerebellum, vestibular apparatus, extrapyramidal system and supported by vision, that is eye. Also, sensory input from the lower limb as well as sensory input from head and neck. And pyramidal tract will help in maintenance of equilibrium by acting on the anterior horn cell. So balance and posture is the role of cerebellum, while vision, posterior column, vestibular apparatus, cerebellum and neuromuscular junction together will be helping in maintenance of balance, posture and equilibrium. So balance is indirectly equilibrium only. So here is a little explanation for that particular. There is a vestibular nucleus which gets an input from vestibular apparatus. Also there is a connection from occipital lobe. There is also a connection of proprioceptive information, tactile information, auditory information to a vestibular nucleus, and this nucleus is connected to cerebellum, to reticular formation, spinal cord or spinal cortex, spinal cord, reticular formations, superior colliculus, extraocular nuclei, and medial longitudinal fascicle. Also it is connected to cortex, and cortex receives the conscious awareness of head position and movements. All together this will have eye movement, head movement, and posture of head and body. Reticular formation will stimulate nausea, vomiting, and can also have altered level of consciousness. So vestibular nucleus will be key part which will be connecting cerebellum, cortex, the input to the vestibular apparatus and output from the vestibular apparatus, which is taking part in maintenance of posture and equilibrium. So you require a sensory input from vestibular, visual and proprioceptive. You require a connections, that is cerebellum, cerebral cortex and brainstem, and you require an output to the motor system which takes part in vestibular ocular reflex, motor impulse to control the eye movement, and motor input to skeletal muscle to maintain the posture adjustment. And all this together will take part in maintenance of balance. So this is a good slide which is taking part in maintenance of balance. So vestibular apparatus, equilibrium, awareness of rotation, linear movements, visual input, proprioceptive input, that is touch. All these inputs are given to cerebellum as well as brainstem, connecting via vestibular nucleus. And from that vestibular nucleus, it gives an input to cerebral cortex, and cerebellum and cerebral cortex are connected by the cerebelloponto fiber, cerebellum to pons. And then there are connections from brainstem to medial longitudinal fascicles, which takes part in vestibular ocular reflexes. So brainstem is also connected for those reflexes, as well as brainstem now is connected to the spinal cord centers, spinal cord, for maintenance of posture, that is postural reflexes, and that takes part in maintenance of balance. So you have got an input from eye, skin, joint, muscle, vestibular apparatus via vestibular nucleus, posterior column, also spinocerebellar tracts, skin and eye. All these are connected to vestibular nucleus. Vestibular nucleus is also connected to cerebellum, and it gives an connection to vestibular nucleus. Vestibular nucleus is also connected to cerebellum, and output is given to motor neurons of trunk and limb muscles. So that will take part in maintenance of equilibrium and posture. Also vestibular nucleus is connected to the central nervous system, and brain receives an input regarding the movement of head and neck, as well as from proprioceptive sensation also regarding the body, etc. And vestibular nucleus will also give to what we call as an ocular reflexes, which controls the eye movement. And these are all the things which are taking part in maintenance of posture and equilibrium. Same thing is explained again here. Vestibular receptor, visual receptor, somatic receptor. Somatic receptor will be connected to reticular nucleus, and this vestibular to vestibular nuclear complex. Visual will be also connected. Vestibular is also connected to cerebellum, and then finally this vestibular nuclear complex will give rise to oculomotor reflexes as well as spinal motor control, and both of these together will take part in maintenance of posture equilibrium. Simplified form: input from visual, vestibular and proprioceptive to the brain, and then brain is connected to oculocephalic reflexes, postural control. Also, because of connection with the reticular formation and to the vagus nerve, nausea, vomiting can occur with disturbances in vestibular nucleus. So three system: vestibular, visual and proprioceptive connected to cerebellum, and then because of cerebellar connection to the different structures, you will have maintenance of posture and equilibrium. All those we have discussed. So central nervous system, vestibular nucleus connected to the vomiting center, that is also called as a chemoreceptor trigger zones, vomiting center, and person can have also vomiting because of disturbances in vestibular system. I'll skip all this. These are all detailed collections. We are not interested in much. So balance is the ability to control the equilibrium. So ability to maintain the equilibrium of the body is also defined as a balance. So term balance, equilibrium and postural control are used as a synonymous for the same concept. So either you call balance, equilibrium or postural control. So this is a balance. So to maintain the center of gravity, the structure which takes part in that, we call that as maintenance of balance. You can see here, this is maintenance of balance. Is taking help of the widening of the arms, wide base, you can take the help of stick. Here you are doing a Romberg test, that is Romberg test. You can see here, this is definitely an imbalance. But maybe because of even high heel shoes. So while in rotation also you require to maintain the equilibrium. While movement also you require to maintain your equilibrium. And when you ask the person to walk, and at that time, that we call as a dynamic equilibrium. So whenever he is maintaining the erect posture, look at the position of feet, look at the eyes open or closed, and direction in which he is falling. So while doing that particular test, you have to first ask the person to maintain the erect posture. So just look at how he is maintaining the erect posture. If a person is using a broad base, means he has got disturbances in maintenance of equilibrium. And if he is using the eye. Now in case of a cerebellum, the person will not be able to maintain the balance whether with eye open or eye closed, with a broad base or a narrow base, and he will have a tendency to fall on either side. But in case of a unilateral damage, he will have a tendency to fall on the same side. So if he has got a right cerebellar hemisphere damage, he will have tendency to fall on the right side. But in case of a vermis damage, he can fall on either side or sometime even posterior. So initially person is supposed to stand with the eye open, two legs together, arm by the side, and look for the balance. Now to make it more accurate, person is asked to close the eye. And when he closes the eye, he is supposed to maintain the balance. If he sways, Romberg test is positive, which will be there in a case of vestibular disorder, cerebellar disorder, and in proprioceptive damage, or we call sensory ataxia. So these three will be the common conditions which will produce ataxia. So initially person is supposed to stand with two legs together, eye open, observe, then he is supposed to close the eye, and if he sways around, then it is Romberg test positive. If he is able to maintain the balance, Romberg test negative. Now if you want to make it more accurate, you ask the person to stand with two legs together, eye closed, arm by the side, and stand on the heel or stand on the toes. That will make it more accurate. But while doing this test, you must stand on the back of the person so that he doesn't get a fall. And if he tends to fall, you can prevent the injury. So that should be done. You always stand on the back like this and see that he doesn't get a fall and injury. In sensory, with eye open, he will make an attempt to maintain the balance, but with the eye closed, he will fall down. While in cerebellar, with eye open or eye closed, in both, person will have a tendency to fall, and that is a characteristic of a cerebellar ataxia. And another part in a sensory ataxia, whenever a person walks, person will walk with a high steppage gait. While in cerebellar ataxia, he will have a typical walking style where he will have a truncal ataxia, he will have a tendency to fall on either right side or left side. He will have a, we call drunken ataxic gait. And here, to make it little more sensitive, this is called modified Romberg test, where in a vestibular ataxia, person will start to sway around with eye closed, like here. As soon as the person closes the eye, person will have a tendency to fall. While in case of a cerebellar ataxia, the person will sway around both ways. But in sensory, little tap, person will have an imbalance. That will be in case of a sensory ataxia. So ataxia can be cerebellar, sensory, or vestibular. In case of sensory, classical example, severe peripheral neuropathy like diabetes or alcohol. In vestibular, mainly peripheral vestibular, can be acute labyrinthitis, Meniere's disease, etc. We already mentioned that in case of a cerebellar, person will have ataxia whether with eye open or eye closed. In a case of sensory, the person will have increased ataxia or person will have a tendency to fall as soon as he closes the eye. In vestibular apparatus, the person will, with little minimal support, will be able to maintain the balance. And this will not change with eye open or eye closed. While in sensory, the person will have a tendency to fall as soon as he closes the eye. So ask the person to stand with the two legs together, arm by the side and eye closed. Rhombic test. If person can maintain the balance, normal. If he has got a tendency to fall, it is called ataxia. In sensory ataxia, the person will have a severe loss of sensation in a lower limb. He will try to maintain the balance with two legs apart, arm wide spread out, and with the help of the eye. As soon as he closes the eye, he will have a tendency to fall. In cerebellar ataxia, the person even with the two legs apart, two arms spread out, even with eye open, he will have a tendency to fall. So whether with eye open or eye closed, he will have a tendency to fall. While in vestibular ataxia, person will be able to maintain the balance with the arms spread out, leg apart, and with the help of the eye and little support. And in that, person will have associated vertigo, tinnitus, vomiting sensation, and even hearing disturbances. That will be very typical, which will not be seen in sensory or cerebellar ataxia. So this is a typical. In cerebellar, wide base, sensory, narrow base. He will look down. We are not interested in frontal gait, but cerebellar and sensory, here there is a two difference. Stride, cerebellar, person will have a irregular and lurching, while here sensory will be regular with the path deviation. Rhombic test will be always positive. In case of cerebellar ataxia, in case of sensory, he will have a tendency to fall with eye closed. Heel shin test will be abnormal in case of a cerebellar ataxia, while in a sensory ataxia, person will not be able to elicit that test because he has got loss of sensation. Cerebellar ataxia, while turning, will be unsteady, while in sensory ataxia, that may be, may not be. Postural instability will be more in case of a sensory ataxia rather than cerebellar ataxia. Fall will be there in case of a cerebellar ataxia in a late stage, while in case of a sensory, as soon as the eye input is gone, person will have a tendency to fall. So that is regarding balance and equilibrium. This is regarding a gait. So gait will depend upon tone in the muscle, strength in the muscle, sensory input, coordination done by a cerebellum, and balance. And balance is maintained by visual, vestibular, and proprioceptive sensation with help of cerebellum. So gait will be altered if even tone is changed, either hypo or hypertonia. If the person is muscle strength is reduced in case of a lower motor neuron, or we call as hypotonic muscle, and the muscles which has got reduced power, and if there is an no sensation, no sensory input to cerebellum or cerebral cortex, will also have imbalance and gait will be disturbed. So there will be lot of factor which will be taking part in gait. So all this factor will alter the gait. And while taking a gait estimation, you should ask the person to walk for few minutes, turn around and come back. To make it again more sensitive, person is asked to walk in a straight line. Then he is asked to walk with one step in front. We call tandem walking. Then to make it more sensitive, to walk on a heel or to walk on a toe. These are the different ways of in which you will be testing for a gait. So here you can see walking on a straight line, heel to toe walking, turning back, rotation around the table, hopping in the place, tandem walking, walking on a heel, walking on the toes. These are all the different techniques which are utilized while observing for the gait. I'll be uploading one video lecture on some common abnormal gaits you can see in your everyday practice. So I'll be uploading that. At present, we'll be discussing theoretical side of that. So normal gait is a series of rhythmical alternating movement of the trunk and limbs which results in the forward progression of the center of gravity. You will see here. And gait cycle is a period of the time from one heel strike to the next heel strike of the same limb. That is called one gait cycle. And in that there are two phases in gait cycle: stance phase, swing phase. So two main phases, non-weight bearing and weight bearing. So swing phase will be there, and that will be non-bearing, no contact, and there is no weight on the foot. While weight bearing is a contact phase and there is a weight on the foot. So you've got a stance phase, swing phase. In a swing phase, initial swing, mid swing and terminal swing. While in a stance phase, there is an initial contact where there is a loading response, middle stance, terminal stance and pre-swing. So these are, forget about all this. We'll directly look at the two phases, stance and swing, etc. It is mainly for the person like orthopedic person, etc. to look at all these things. We are interested in a neurological side. So these are all the different phases. We look at the way in which he walks. Here you can see that this is a way in which he walks and this is a swing, what takes place. So there is a gait cycle, there is a stance and there is a swing phase. And while walking, this is called tandem walking. Walking in a straight line. And this is called hopping. So you will test in all this method. Indirectly, this will be very useful to identify ataxia, more common. So this is tandem walking, this is walking on a toe, this is walking on a heel, this is again a tandem walking. Here the person is walking with a broad base, eye fixed to the ground, and here he is hopping. So that is tandem walking, this is walking on the toe, this is walking on the heel, this is hopping, this is broad base, and while doing that you can look for sensory ataxia, cerebellar ataxia, etc. And gait can be affected by orthopedic like joint disorders, weakness, amputation, ankylosing, deformities, all those things. But neurological wise, you will come across hemiplegic gait, Parkinson gait, cerebellar ataxic gait, etc. These are the common neurological disorders which will be affecting the gait. So in hemiplegic gait we call circumduction gait, in Parkinson we call short shuffling gait, in cerebellar drunk man gaits, paraplegia spastic gait, in poliomyelitis flaccid gait, and in a diplegia scissors gait. So these are the different types of gaits you can come across. Now to individually to explain that, in a hemiplegic gait, typical circumduction, a very nice representation of hemiplegic gait is there in a video lecture. We'll be showing you that. Even that Parkinson gait, or we call as short shuffling gait, is also shown that. And in a cerebellar ataxia, you will have a drunken gait. That is also shown very nicely in that particular. Parkinson gait will be typical short shuffling gait, eye glued to the ground. Poliomyelitis will have a typical gait. So you can have a spastic gait, scissors gait, typical propulsive gait, or we call short shuffling gait in Parkinsonism, high steppage gait, waddling gait in a Duchenne myopathy. Cross leg gait will be very common in cerebral palsy, also in case of paraplegia with spasticity. You can have a Gower's sign, that is also shown in that video lecture. And also some of the medical condition can disturb the gait, like orthostatic hypotension, vertebrobasilar insufficiency, intermittent claudication, chronic lower limb edema. COPD also can have abnormal posture, gait and disturbances in gait. Musculoskeletal condition like osteoarthritis, rheumatoid arthritis, foot and hip problem, fractures, arthralgia, all those can produce disturbances in gait because of musculoskeletal condition. And neurological condition, we already mentioned, Parkinson is classical, then hemiplegia, paraplegia, cerebellar atexia, those conditions will have definitely, and there will be lot of other conditions also can produce disturbances in gait. Also because of mental disorders like depression, dementia, drugs can also have abnormality in the gait. So I end my lecture here. We'll be having a video lecture on gait. You can go through that and you can see the different types of Trendelenburg gait, waddling gait, autalgic gait, etc. Antalgic gait. So at the end of this lecture, I thank you all for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. If you like this particular lecture, please don't forget to press button like and subscribe. You can give your suggestions. I'll try to improve. See you in next lecture.